Here we go. Evening, everybody that's joining us. I apologise for any background noise that comes from my end. I've got a 5-month-old baby that I'm locked down with, so she doesn't quite understand the politeness around Zoom webinars yet. And just wait for a few more to join. We've not quite got all of you yet. Okay, let's get going. Good evening, everybody. My name's Ollie Coburn. I'm part of the leadership team at BASRaT. Thank you all for joining us for what's the third now in our lockdown webinar series. Tonight's a bit of a different one. We're really pleased to bring tonight in partnership with Steroplast as a bit of a replacement for this month's Injury Rehab Network Northwest. So Andrew Watson from Steroplast has joined us. He'll do a bit of an intro, tell you a bit about Steroplast and the Injury Rehab Network. A little bit of housekeeping, how we're going to run things tonight. David is going to do his presentation. Throughout that, if you look on whatever device you're looking at, there should be a Q&A button, and you can type any questions that you've got for David. Before you post one, just have a look at what's been posted by other people, because you can upvote them. If you do that, they'll come to the top of the list. And what we'll do, once the presentation is done, we'll pick some of the popular questions and we'll cover those off and see how much time we've got. I guess we'll be going for about an hour tonight, so it should be really good. Andrew, I'll hand over to you, mate, and I'll let you take it from here until we hit Q&A.
All right, thanks very much, Ollie. Hi everyone, evening. Sorry to pull you away. It's nice and sunny up here in the northwest. So yeah, like Ollie said, really pleased that BASRaT have managed to help us out to bring this networking event online. The Injury Rehab Network came about just over a year ago now, through our work that we do with sports injury professionals in the northwest. So that includes different organisations and physios, therapists, rehabilitators, people that are working in private practice with sports teams, academics, a whole range of different people, national governing bodies. And it was really just an opportunity to bring people together so that they can collaborate, but also to hear from experts. So we're really pleased that we've had a range of different experts that have spoken, and usually we host the events as physical events where people come and they can meet in person and hear from a kind of an expert guest speaker. But obviously due to the current situation, we're taking things online, and as I said, thanks very much to Ollie for helping out, and thanks to David for sort of kindly offering to help firstly, but also for agreeing to work with us online. So it's the first time that we've tried to do this. I know that Ollie and BASRaT have managed to do a few successfully, so hopefully this one will go well too. Just before we start, I'm from Steroplast Healthcare, and we're really sort of a medical consumables supplier and manufacturer. So we're obviously keen to help out wherever we can. And if you have got any feedback in terms of things that you need, particularly at the moment with the coronavirus situation, that's obviously a challenge for us as well. But if there are things that you particularly need, we'd be really interested to hear your feedback and any ideas that you might have. Equally, if you've got ideas for future events or guest speakers, then please do let us know as well. So I'll obviously let David introduce himself, but before we do that, one of our contacts is a ex-professional boxer, and she kindly she couldn't make it this evening, but she kindly gave me a bit of a testimonial, and she was really saying, this is Stacey Copeland. So for those of you that have heard of Stacey, she's an ex-Commonwealth boxer, and she had a bad hand injury and a previous operation that wasn't successful, and she's given me kind of a glowing testimonial really of how David managed to help Stacey and get her back and fighting again. So I think that's hopefully a good introduction to the work that David can do, and yeah, really interested to hear more about David's work. So thanks Ollie, thanks David.
Brill.
Thanks, Drew. Thanks, Ollie. Yeah, it's nice to hear from Stacey. I didn't realise she got in touch with you, but she's a great girl. So thank you for that. And nice to virtually meet everyone out there. As we said, we'd rather be doing this face to face in other circumstances, but due to the crazy world we're in, we'll make do tonight. Hopefully, we'll get to have some good discussion and learn about tendinopathies of the hand and wrist. So I'm just going to try and change my screen so you can all see the presentation, hopefully. Okay, Ollie, is that up on your screen now?
Perfect, mate. Yeah.
Fantastic. Okay, so okay, so thank you very much to Steroplast and Anderw for inviting me to talk this evening, and also the British Association of Sport Rehabilitators. I can see we've got nearly 200 participants now from mainly around the UK, but also internationally. So hello to everyone. Thank you for joining us. My name is Dave Murray. I'm a consultant hand, wrist and elbow surgeon who I work out of the northwest of England in the UK. I started Manchester University in 1999, where I studied medicine. I then went on to complete the Northwest orthopaedic rotation. I studied my fellowship in hand and wrist surgery at the world-renowned Wrightington Hospital under the guise of Professor Trail and Mr. Mike Hayton. I now work in the NHS in the region, the Northern Care Alliance throughout Salford and North Manchester. And I'm also lucky enough to work in the following centres: the Manchester Institute of Health and Performance, based up just next to Manchester City's football stadium, also in a lovely new hospital in Wilmslow called the HCA 52 Alderley Road Hospital, and in the new Orth Team building in Didsbury in Manchester, where we get to see quite a few high-level athletes and not so high-level athletes as well, our Sunday warriors with lots of different injuries. So we're going to talk about hand and wrist tendinopathies, quite a huge topic, and we literally could spend all day, but we're going to try and restrict this down to the main ones and ones that I think that you will get the best knowledge out of from me this evening. We're going to look at what is actual tendinopathy, the anatomy surrounding the tendons of the hand and wrist, and a bit of a brief recap on hand and wrist anatomy as well. The common sports-related tendinopathies are ones that certainly come to my desk most of the time, how they come about, how we treat them, and also the treatment options we've got from both people like yourselves, physiotherapists and surgeons as well, and the outcomes of these treatment options. There's plenty of time for questions at the end, so as Ollie says, please just put the questions through, vote them up, and hopefully we can have some good discussion at the end of the session. And I've got no conflicts or interests at all. Okay, so a tendinopathy. People use this word, tendinopathy, tendinitis, tendinosis, sprain, strain, quite loosely, and I think there's a lot of ambiguity in that. For today's sort of web conference, we're going to look at tendinopathy, and we're going to class it into these three terms, really. Overall, it's an adaptive response of a tendon to a repetitive trauma or a stress. Now, that can be a normal phenomenon as well, really. And that's when we get the early stage, a reactive tendinopathy. The tendon responds to this rapid load, an increasing load or trauma, and it becomes thicker and stiffer to do its job. It can progress on, however, to a pathological state where you can get a tendon disrepair. This is when you get the increased loading, which continues, there's no rest, and then you get a change. You get a matrix breakdown. So the actual biochemistry, the biomechanics of the tendon becomes broken down. You get increased vascularity, increased inflammation to the area, and it turns into a bit of a vicious cycle, which leads on to a degeneration of the tendon. This is a chronic problem. You then get collagen disorganization, so it's not laid down as it should be, and this can then lead to a massive change in the biomechanics, and rather than the tendon doing what it ought to, it actually can partially tear or completely tear, which can be quite catastrophic, especially for our athletes. If we look at this quite simple diagram by Cook and Purdom, published in the British Sports Medical Journal back in 2009. It's quite a good way to look at it and simplifies it. So green is good, red is bad. We have a normal tendon in the middle. Ollie, can you see my cursor? Yeah, great. A normal tendon, we have an optimized load. The tendon then adapts and strengthens, and it remains a normal tendon. Or if it becomes very painful, we can appropriate the modified load, we can cut down, and we get back into the loop of being a normal tendon. It's when we have this excessive load or other factors, which we'll go into later on, that we lead on to the reactive tendinopathy and into this cycle of disrepair. We can stop this at any time by stopping the load, stopping the frequency or the increased frequency, and hoping that we get back into the normal tendon again. And we'll go through some of the factors that cause this problem. So I'm hoping that the sound doesn't play on this. We'll just try and turn it down because it's not the best background music. Well, let's have a little look. There you go. So this is a very quick video, which I hope projects well onto your screen. Obviously, it's skeletal here, just showing the bones of the carpus, distal radius and ulna, and the metacarpals. I'm trying to show here that with that dart throwing motion of the hand, so from a ulnar deviation into a radial deviation, any movement causes all the tendons around the flexors and the extensors of the wrist and the fingers. They all move synergistically. You can't have one set of tendons moving without the other. It's a little bit like your biceps and your triceps. And that's very important with tendinopathies because it's very difficult to just treat one singular tendon without strengthening the corresponding synergistic tendons. So keep that in your mind, and we'll come back to that a bit later as well. So into the anatomy, flexors and extensors. Quite simple. We have flexors and extensors for the carpus, the wrist, for the thumb, and for all the fingers. The flexors are split into the flexor carpi radialis, the flexor carpi ulnaris, flexor digitorum superficialis and profundus, and the flexor pollicis longus to the thumb. If we look at a cadaveric model, all these flexors come from the medial epicondyle, or the common flexor origin. So on the inside of the elbow, the bony prominence, all these flexor tendons and flexor muscle groups come from here, and this is why more proximally is where you get your golfer's elbow, which is another talk, but we're going to look more distally now into the tendons themselves. If we look in the hand and the wrist, starting on the left-hand side of your screen, we have the palmaris longus tendon, which goes into the palmar aponeurosis, this big triangle of fascial tissue, which is just underneath the skin, which maintains the skin tight down, hence why you can't lift the skin on the palm very easily, whereas on the back of the hand, it's very easy to lift the skin up. If we remove the palmar aponeurosis, we can then see the tendons in all their glory, and they come through the carpal tunnel. So this little structure across here, the transverse carpal ligament. Through this tunnel lies our flexor tendons and also our median nerve. And you may be aware of the carpal tunnel syndrome, when the median nerve becomes compressed in the carpal tunnel, and that's due to increased pressure just underneath the transverse carpal ligament. If we take away the transverse carpal ligament, again, you'll see the median nerve in full coming through to supply the thumb, index, middle, and half of the ring fingers, and the flexor tendons coming through. So they all bunch together quite closely and then spread out to the fingers and the wrist and the thumb. If we look at the extensors, slightly different. The extensors are arranged in actual separate compartments. So whereas the flexor tendons go through one large tunnel, the extensors are arranged in separate compartments. Looking at this cross diagram, working away from the radial side over to the ulnar side of the wrist. So this is a cross section taken approximately this level here, just over the carpus bone, so the radius and the ulna. You'll see one compartment, the first compartment, holds the APL and the EPB, the tendons that move the base of the thumb into extension and abduction. We've then got the second compartment, the ECRB and ECRL, the extensor of the radial side of the wrist. In the middle, we have the EPL, the third compartment, which is the extensor at the end of the thumb, allowing for full extension at the IP joint, and also retropulsion, lifting the thumb up into a backward motion. In the middle, we have the EDC, extensor of the fingers, and also to the index finger, a separate one, and then the EDM, extensor to the little finger, and its own compartment, which is really quite important. We'll spend quite a bit of time on that later. Sat in this small groove of the ulna is the ECU tendon, which is the extensor carpi ulnaris. The main tendons of the wrist are the ECRB and L on the back, and ECU, and they allow the wrist to fully extend and both ulnar deviate and radial deviate. So again, looking at a schematic of the extensors, we have this large sort of ligament over the back, which is split into compartments underneath, which we've just seen a cross section of, and the extensors coming then into the respective fingers, thumb, and into the wrist. So just to break that down again, so you're all clear, compartment 1, we have the APL and EPB. Compartment 2, ECRL, ECRB. Compartment 3, crossing over, which is the EPL tendon. And if you do lift your own thumb up backwards, that's the tendon which sticks up when you lift your thumb back. And then the 4th, 5th, and 6th compartment holding on to the ECU in number 6. So, if we look at these tendinopathies, there's a couple of studies done over the past, and they all show an increased risk, as you would expect, in highly repetitive and highly forceful occupations, including that of top-level athletes and all athletes who are racket sport players, golfers, etc., etc. If you look at some of these pictures, the force this weightlifter's putting through his wrists and hands isn't an everyday normal force, and that's taken years of training, and his tendons have adapted apportionately and appropriately to this. But with wrong technique, wrong positions, you can get a sudden instant overload of the tendon, which can cause or lead into a tendinopathy or a rupture, or from sustained overuse of wrong technique, this can progress as well. Certain positions of the hands, such as cyclists, or certain movements, such as a flick of the wrist back, in racket players also. So any sports involving the hands with an increased risk of, but some more than others. We're going to start with the radial side wrist and the base of the thumb, and we're going to look at Deca-Vein's tenosynovitis, DQT, the most common wrist tendinopathy that I certainly see in athletes. We've already mentioned in the first extensor compartment, on the back of the wrist here, we have the EPB and APL tendons. So they abduct the thumb and extend the thumb as well. People who come to clinic, they often present with these classical 3 symptoms. They have tenderness just over the radial styloid. They have swelling, which can often be as big as sort of, half a golf ball sticking up, and it can come on quite acutely, very, very tender to touch, very red. And they also have this thing which is called a positive Finkelstein's test. Now, if you haven't heard of a Finkelstein's test before, I'll go through that for you. Let's come on to the Finkelstein's. This is a Finkelstein's test where, originally described, the wrist is held in neutral with the thumb inside the fist, and then the examiner asks the patient to move the wrist into a ulnar deviation, and hence stretching the APL and the EPB tendons. Now, actually, if you do it yourself and you put your thumb inside your fist and squeeze quite tight, that can sometimes cause a little bit of discomfort anyway. And I think it's much more sensitive to put the thumb outside the fist and then gently move the hand down. Now, in most patients with this pathology, you'll get probably as far as here before the patient either hitting the roof in pain or trying to hit you to get them off you. So it's very, very, be careful with that one. But it's a pathognomonic test, Finkelstein's test, for Deca-Vein's tenosynovitis. Looking at the anatomy a bit closer, we have the anatomical snuff box, where I hope you can see in this light, it's a little hollow produced just in here when you extend the thumb back. In the olden days, that's where the sailors used to put the snuff and snort it out of that little pocket here, like a tobacco hole. It's formed by the radial artery at the bottom. We've got the EPB at the bottom of the triangle, if you will, and the APL, and then the EPL, the extensor pulsus longus, along the top. Now, these tendons lie within a sheath, and when that sheath becomes inflamed, due to the reasons we've been through, the increased trauma or repetitive stresses, you get this tendinopathy inside. Differential diagnosis is, well, any sort of pain that you can get on the radial side of the wrist, basically. Intersection syndrome is another topic, which we'll come on to in a second, but it's basically where you get a crossover of the first and second compartments. It's normally a bit more proximal to that, with a slightly different presentation, but can be confused with Deca-Vein's. Osteoarthritis or degeneration of the first CMC joint, so the joint at the base of the thumb between the first metacarpal and trapezium, or in the STT joint, so between the scaphoid and the trapezium and trapezoid. more in an older patient, but an athlete who had an injury before and some cartilage loss, again, we can exclude that with an X-ray. And radiographs are always helpful on radial-sided wrist pain, as well as showing any degeneration or arthritis, whether it be degenerative or post-traumatic. It can also sometimes indicate a very small bony spur, which can lead on to the decurvatus tenosynovitis. It may have been that the athlete had an injury in the past, the bony spur has developed, puts pressure on the tendon, changes the way the tendon moves, which leads to a tendinopathy, or it could also be a reactive osteophyte as well, where the tendinopathy is so bad and so inflamed that the bone actually overgrows and forms a little tiny spur, and again we're into that vicious cycle. So if we look at a radiograph, just about a small arrow, and I hope you can see that, this is abnormal. This is a small little osteophyte of bone or a bony spur, which, as you can imagine, when the tendons run over here, causes more inflammation and more pain to occur. And if that's the case, we can simply make a small incision, remove the bony spur, release the tendon, and often the pain will go for the athlete. On an MR scan, you can see this big area of high signal here and thickening of the tendon. For patients, for athletes who come in with a radial side, we'll do an X-ray. If it doesn't show a bony spur, I will progress on to either an MR scan or ultrasound scan. With the MR scan, you get an increased signal around the first extensive compartment. You get increased fluid within the sheath. Now, it's normal to have fluid within a tendon sheath. That's what gives you the lubrication for the tendons to move. But generally, if the quantity of the fluid on a cross-section is bigger than the tendon size itself, excuse me, then that's pathognomonic and indicates decurvatus tenosynovitis. Also, an increased tendon size, back to our original diagram, you get a thickening of it as well, and occasionally you can pick up small partial tears. Ultrasound scan is a dynamic modality, so you can look up and down the tendon while the athlete or the patient is extending or flexing the thumb, and you can also use a Doppler with the ultrasound to show the increased vascularity and compare it to the opposite side or opposing tendons. And here's a cross-section of an MR scan to show you. You'll see the white fluid surrounding the black cross-section of the tendon, and you can see that's far increased compared to the fluid around the other black tendons on the back of the wrist. On this view on the MR scan here, you'll see a thickening here of the fluid all the way around within the sheath of the thickened tendon here as well. And ultrasound scan, and this is showing the increased vascularity on the Doppler. So how do we treat it? Well, conservative management is 80% successful for all these cases. Physiotherapy is drilled into the patient. The earlier you can get this, the better it is for the patient. Eccentric exercises, so stretching the tendon out under load. Ultrasound therapy as well, non-thermal ultrasound therapy really helps with this. I give my patients, if able, a 4 to 6 week course of physiotherapy. That may or may not include splints, depending on how bad they are and what they do for a living. And I see them back again. If they're recovering and doing well and the pain is reducing, we will continue. If they've hit a wall and they've plateaued and are still in pain and can't function with it, or if it hasn't helped at all, or indeed if they've got worse, we move on to the next step of treatment, which in my hands is an injection, a steroid injection. We'll always do injections with concomitant physiotherapy. The research has shown that both together are far better than doing one alone, which is common sense really. And also, it's been proven that injections under ultrasound are far better than just doing the injection in clinic blindly. So I'll always ask my radiologist to do this for me under ultrasound and put a steroid all the way around the tendon to decrease the inflammation, decrease the symptoms, get the athlete back to playing as soon as possible. I think the problem here, although that's quite straightforward, comes when you have an athlete in the middle of a season, or they've got a competition coming up or a fight coming up, and they just want to come to your clinic and have an injection straight away. Again, that all involves the ethics and counselling the patient and telling them that if we don't get it right in the long run, it might be a very chronic problem for them, which may lead to surgery, which with some careful physiotherapy and rest and taking the frequency and load off, could save them surgery in the long run. As long as the patient is consented and the risks are explained, they often make a decision with their agent, and we go ahead with that, but I'll always try and push for conservative management in the first instance. So when do I operate? Well, if a steroid injection has failed and not given any benefit, or if the thickening of a tendon is so bad that when the first extensor tendons move out of the tunnel, out of the sheath, they actually get stuck and trigger. Now, trigger fingers are very common. You may all have heard of trigger fingers, where they flex the tendons, get caught in the A1 pulley, whereas triggering of the first extensor compartment is uncommon. I have seen it once or twice, and that's certainly an indication for me to operate if a patient can't actually flex the thumb down or move the thumb back because the tendon's inhibiting that. So how do we do it? How do we operate for DK veins? We can do it under a local anaesthetic or a general anaesthetic, patient choice really. We release the compartment fully. I do a slightly dorsal incision to prevent the tendon from slipping down when the wrist is being pronated and supinated. You have to ensure that all the slips of the APL are released. The APL can often be in 4 or 5 different slips going distally, and you have to make sure you've got all of those. If you leave one which is compressed, it can carry on with pain. And also, in most cases, there's just one tunnel for both tendons. But in a few cases, you do find that there's some septations and some septum within the sheath, and you have to make sure that you get a little hook and pull the tendons up and watch the thumb go into abduction and extension to ensure you've released them fully. And there's a picture of the operation, or a cadaveric model here. So you'll see the abductor pollicis longus tendon coming across here, and we incise the sheath at the top, and then you've got the extensor pollicis brevis just next to it, which is actually lying in its own sheath. So you have to explore for that and release that one as well. And just a picture here to show quite nicely that the EPB and the EPL tendons are in one structure where the arrow is, whereas the APL appears to be one tendon proximally, but as you go distal, it actually splits up to form 3 or 4 different slips in this model here. So we mentioned the differential diagnosis of an intersection syndrome before with DK vein, sticking on the radial sided wrist pain, otherwise known as an Osman's wrist. So very common in professional rowers, people who spend a lot of time rowing. And again, you get the pain and swelling to the distal radial aspect of the forearm. It's normally a bit more proximal, about 4 to 6 centimetres proximal to the radial styloid, whereas our DK veins is within 1 to 2 centimetres of the radial styloid. And this is where the first extensor compartment crosses over the second extensor compartment. You get basically a friction between the 2 muscle bellies and the tendons, which leads to inflammation, tendinopathy, and sometimes even a bursitis and collection of fluid. Caused by a repetitive flexion, extension with eccentric loading. In everyday jobs, lots of hammering as well. So lots of joiners who come in will have this pain, often wrongly diagnosed as DK vein tenosynovitis until we get some investigations which show it's a more proximal lesion. Rowing, racket sports, and also really common actually in the winter sports season. You get a lot of patients who, if they are of the people who can afford to do this, they go into a deep powder helicopter skiers. I've never done this myself. I do enjoy skiing, but I haven't had the chance to do this just yet. Where the helicopter takes them to the top of the mountain, the virgin snow, they're dropped off, and they make their way down. Very, very physically demanding. Lots of force put through the wrists with the poles into the powder snow, and they come back with this pain, and that's known as a bugaboo wrist. Don't ask me why it's called a bugaboo wrist, but I think that's a technique that the deep powder helicopter skiers use. So one that you'll probably remember now if you do see a skier with dorsal, distal, radial pain. Often get an audible crepitus, so you can put your thumb over the area of most pain, ask them to flex and extend the wrist, and you can hear a creaking type sound really and feel it under your thumb. The provocative test for this is pain on direct palpation, just where the first extensor and the second extensor compartment meet. This breaks it down nicely, which looks quite simple, whereas in real life there is quite a lot of crossover between the 2 areas, and you'll get a patient who's presenting with pain right in this area here, in between the 2, and that's where investigations can be really helpful. Just to show you the crossover point, here's our second compartment with the ECRB and ECRL next to each other, coming through the second compartment in the extensor retinaculum, and then you've got your first compartment. So distally they are separate. As you come down the wrist, they cross over, and this is the area where the patients get the pain in Osman's wrist or intersection syndrome. If we look at an MR scan, you can see where the tendons overlap and the amount of fluid over the top compared to normal with very little fluid. Treatment, if there's any doubt with the diagnosis, you can put just a diagnostic local anaesthetic injection into the area in clinic, ask the patient to wait for 5 to 10 minutes in the waiting room, get them back in, ask them to move the wrist. If the pain has gone, normally it's diagnostic enough for me to say you've got an Osman's wrist there. Again, a bit less now with physiotherapy, about 60% get a permanent relief with conservative treatments, not just the physio, but also taking away the source of what's making it bad. So taking away the rowing for a period of 4 to 6 weeks with concomitant physiotherapy if it's severe. If it's a mild case, you can still allow them to row, but reduce the frequency, reduce the load put through the wrist. Steroid injections can be tried again in the same way as deco veins. Again, I would definitely ask them to be done under ultrasound to get them in the right area. And if these techniques fail, we're on to surgery. So the incision's right over the point of pain. We can mark it on the skin. After surgery, immobilise the wrist for 10 to 14 days, and then into a physiotherapy program, normally returning to sport at around 8 weeks. Here's the skin markings of the second and first compartment. This is the EPL, the third compartment coming round with Lister's tubercle, which is a small bony landmark on the back of the distal radius. Acts as a sort of pulley for the EPL to come around. Incision made right over that point, which you always mark preoperatively to find out where the patient's most painful. You go down, may not show very well because it's black and white, but you literally just release the muscle belly, release the tendons apart, clear any bursitis, and debride the area. Okay, so that deals with the, how are we doing for time? We're okay. That deals with the radial side of the wrist. Moving on to the ulnar side of the wrist, then basically the ECU tendon is what I'm going to talk about most now. This is the second most common presentation for wrist tendinopathies, very much linked with tennis and rowing. Pain over the ulnar aspect through compartment 6, which I showed you previously, that cross section. The difference with the ECU tendon is that the ECU tendon actually lies within a subsheath, just to confuse matters, within the 6th compartment, which can lead to some problems for us as surgeons and you as treating physicians as well. The actual tunnel itself, the sheath, lies over the distal 2 centimetres of the ulnar. And I showed you before, it lies in a groove in the ulnar. And I'll try and show you a picture to explain that here. This is quite a nice drawing. If we look at it from a cross section, you'll see the blue is the fibrous tunnel. Part of the extensor retinaculum, here's the 5th tunnel, here's the 4th, here's the 6th, which is where the ECU lies. But the red shows this very thin subsheath underneath. And that keeps the ECU tendon sitting in the ulnar groove. Because when we pronate and supinate the wrist, the radius moves around the ulnar and the ECU moves as well. And it has to stay in that position to be effective. And if we take away the 6th compartment, we're still left with the subsheath. This isn't a normal subject, normal individual. Keep that in your minds. So patients present often with a gradual onset of pain, getting worse and worse with the more they do. They get not so much acute swelling as on the radial side, but a thickening around the ulnar side, swelling over the ulnar head, pain on ulnar deviation, so the wrist going over this way, or forced ulnar deviation, and also extension. So we said that the main function of the ECU tendon is to extend the wrist and to ulnar deviate the wrist. Again, a local anaesthetic can really help because on the ulnar side of the wrist, we've got other things that can cause pain, especially the TFCC, or the triangular fibrocartilage complex, which again, we could spend all day talking about. We'll just touch on it today. The TFCC helps to keep stability between the ulnar and the distal radius. It can be torn either in a central or the peripheral aspect with a more of an acute injury. So the history does a lot to help us in determining what the cause of the pain is. but a local anaesthetic just superficially into the ECU can help differentiate between the two. Again, a lot of patients will come to see you, especially the athletes, and they've just pushed it and pushed it and pushed it until it becomes so sore that they can hardly move their wrist. In somebody with mild symptoms or moderate symptoms, you can ask them to ulnar deviate against resistance and they will point to their pain. You can ask them to extend against resistance and they'll point to their pain. Often, if they're so sore that they don't want to do that, you can do something called a synergy test. Now, we said before that you can't really move one tendon around the wrist without the other tendons moving as well. And this is a really good test. And basically, you can do it on yourself. If you ask the patient to move the thumb out or to extend the thumb, the tendons they are using is the extensor pollicis longus and the extensor pollicis brevis. Now, both of those tendons we know cross the wrist joint. So when the body tenses those tendons, because it's crossing the wrist joint also wants to move into radial deviation. So to stop that from happening, the brain sends a message when you're moving your thumb to the ECU tendon to tighten up, and that's involuntary. So if you put your finger over the ECU and simply move your thumb out to the side, you'll feel the ECU contracts without you voluntarily doing that. So it's called a synergy test. So in a clinic, you can ask the patient to open their thumb and middle finger up, pushing the thumb away, with your other hand over the ECU, and you'll feel it contracting, and they'll jump with a sharp pain in that side. So quite a nice test to remember, the ECU synergy test. MR scan, again, I get this for all the patients who come in with ECU symptoms. You'll see the yellow star showing a normal ECU, nice black cross section of a tendon. You'll see the subsheath pointed by the red arrows, very thin subsheath coming across, sitting nicely in the groove, and then the actual compartment is the blue arrows. In a pathologic subject, you have thickening of the tendon. You have some fluid in between, some interstitial longitudinal tears. It's very hard to make out the subsheath over the top, and really the subsheath here altogether with the actual compartment and probably being ruptured there. Also, you'll note the consistency of the bone in a normal subject is nice and white throughout here on these sequences, on these MR sequence, whereas you'll see some bone edema compared to the rest of the ulna and the radius, showing again some bony edema, some bruising within the bone, some reaction of the bone due to the inflammation around the tendon here. Another specimen showing lots and lots of fluid around, and you'll also see now a nice groove of the ulna. The tendon is starting to slip out here. So the subsheath has given way and the tendon's slipping out of that nice groove. So for our athletes and in the sporting world, the ECU behaves a bit different to the tendons. It doesn't really have one straight line of pull. If we look at anatomical studies, then we can see that in pronation and supination, the ECU lies in a different position. So with the wrist in a pronated position, it lies straight with very little tension through it. In a supinated position, it actually kinks because of that subsheath and because of the pulley. So if you look at this in schematic, in pronation, one nice straight line through the subsheath into the wrist. In supination and flexion, there's a kink. And we can see that on a live model here. So pronation, one straight tendon coming through the sixth compartment. And in supination, you can see just how much that tendon kinks around. So in that position, the tendon is under more force and more pressure than it is in the other position. And if you look at some sports, like when your hand is in a flexed or deviated position, in that supinated pose, that's when most of these injuries occur. And if you're held in that for a long time with lots of force going through, you're more likely to develop ECU symptoms. And again, tennis players are a common example of the position of the hand for this as well. And this is one of the most common injuries we see in pro tennis players. So how do we treat it? Again, we always start with our non-surgical options. Rest, take away the insulting factor. Don't play tennis, don't play rugby. We can splint it for parts of the day or a few hours of the day to give the tendon some rest. And what we like to do is splint the tendon in a resting position. So we extend it because the ECU is an extensor. So if we flex it, we're stretching it. If we extend it, the hand is held with the splint and the tendon's not having to hold it there, so it can relax and become floppy, if you will. And on the deviation to take the tension off as well. Management load, so returning to sport at a decreased frequency, decreased load. Remove from play if able. Isometric exercises, so strengthening in the same position. Eccentric as well, if it's been going for a long time. Steroid injections, but being aware that there is a slight risk of tendon rupture, although very, very low, but it must always be counselled to the patient. I like to say that the movement and the strength has to return to 80% of the opposite side before you return to your sport. And we measure that with a dynamometer and look at the angles with the physiotherapist. I think if you return to sport, especially at a high level, with anything less than that, you're going to take 1 step forward and 3 steps back, and it's going to take you double the time to recover the second time round. And that's a nice way to put it to the patients. Sort of splint we use, just a simple thermoplastic custom-made splint holding the hand in, all the deviation and extension. Surgical, we can do a surgical release depending on the severity. Again, quite straightforward in terms of surgery. The tendon lies within the sheath. We go in between the 5th and 6th compartments and we release that compartment. If the subsheath is still intact, we would normally leave the subsheath unless it shows any thickening, which we can debride it. If the subsheath has become ruptured, which I'll talk about in a second, we really have to reconstruct it, and we can use a sling of the extensor retinaculum to form a new tunnel, really, but with a lot more space than before, and again, making sure it's debrided so that all the scar tissue, if any, has been taken away. So that was our original picture, showing the tendon in the ulnar groove. Sometimes if the subsheath ruptures, then rather than just pain and swelling, then the tendon can become unstable, and it can click and it can dislocate out of the ulnar groove. This ranges from a minor subluxation, a click on pronation supination, to actually the tendon can come out of place and the patient can't move the arm back without having to massage the area and get it back into its position. So we call that forearm locking. Very unusual, but can happen. Different ways this tendon can slip out. You can have a radial-sided subsheath tear, an ulnar-sided subsheath tear, excuse me. You can get a tear and the tendon can lie on top of the sheath, so it's never going to heal itself. Or you can actually just lift off the subsheath, sort of peeling it off, and the tendon can sit in a little pocket formed. Okay, so depending on how the subsheath ruptures, which is looked at by investigations, would depend on how we treat this. This is a stripping injury with the pouch. If that happens, and we can get it acutely before this goes into a full dislocation, we can often go in, relocate the tendon and put a small anchor down into the subsheath just to restore its anatomy, really. This is an ultrasound scan. Again, ultrasounds are great for this because it's dynamic. So you'll see that in pronation, the tendon lies within the groove. And if you did an MR scan, although it would show you inflammation and swelling, it would show you the tendon being in the groove because it's a static investigation. The patient lies in the MR scanner with the hand in one position. Whereas the ultrasound scan, you can do it both in pronation and supination, and the radiographer or radiologist can move the probe around at the same time. And you'll see here, here's the groove, and the tendon slipped right out on top. Here's an MR scan with it in the correct position. So the groove's here, and the tendon slipped out. And one test we can do in clinic is a test described by CYNG, one of my colleagues at the Orth Team Centre, and Mike Hayton, again another colleague, the ice cream scoop test, which sounds very simple, and it is. You basically hold the patient's wrist with your index finger and middle finger over the ulnar side of the ECU and ask the patient to pretend they're scooping out ice cream from a tub without rotating at the elbow or shoulder, just using the wrist. And by doing that motion, going from flexion, extension, pronation, supination, you'll often feel the ACU click in and out of place. It can be quite painful for the patient when that happens. So management, if we get these in, the instabilities where they've ruptured and dislocate out acutely, you can treat this in a long arm cast. This has been discussed in the literature. However, a bit of a caveat to this in that we tend to see the acute cases in the professional athletes who are brought in because any professional athlete nowadays who has any injury gets a scan straight away by the treating physician in a department or a club, which is good for us because we get to see the injury straight away, maybe a little bit overkill sometimes. But if we see it, then we have got a chance of treating conservatively. But you need to put them into a long arm cast to take away any pronation, supination. You treat them in pronation, radial deviation to keep the ECU in the groove, and you have to immobilise it for 6 to 12 weeks. So again, that's really a season over for any professional player, or a competition over. So much rather, the athlete would rather go for acute surgery to fix this and get back as soon as possible. And also, although this does work, there's no guarantee it will work. And it's hard to say to an athlete, we'll try this method for you, but maybe in 3 months' time, we might have to operate anyway. So it's about counselling the patient. If we do need to reconstruct and go to surgery, this is my preferred choice. It's basically to take a strip of the retinaculum, fold it back on itself, and suture it in here with the tendon in the position where I showed you before of function. So you tighten the tendon up so it's nice and strong, and you let the tissues heal in a cast for 4 weeks, and then start slow physiotherapy. There are other techniques you can do. You can use 2 anchors to form a subsheath over the top. Or you can simply, as we said before, go in and reconstruct the subsheath here. Okay, that's, I think, 45 minutes. Is that okay for time, Ollie?
Some great timing, yeah. We've got some good questions as well, and we've got an answer to Bugaboo's wrist for you. And
oh, good. Okay, yeah, tell me.
So, Judy, thank you for that. It's from heli skiing in the Bugaboo Mountains in British Columbia, Canada. So there we go.
Very good. Is it Judy, you say?
Yeah.
Oh, thanks, Judy. That's great.
So, okay, there's probably a couple of questions that are quite similar. We'll go with those first. Chris's question is getting a lot of love. 13 upvotes for that one.
Okay.
So we're talking about ultrasound therapy in the management of de Quervain veins. So Chris is essentially questioning efficacy of ultrasound therapy. I know it's a bit of a hot potato at the minute. Is it a condition-specific use of ultrasound therapy? Is it something you use more widely?
Again, individual circumstances, severity of it, really. By the time the patient comes to see me, normally, for the patients that I see in the athletes, they have been through the physiotherapy and they have tried all modalities, including ultrasound. And it's the patients that 5% really that it doesn't work in and they require surgery. The evidence would suggest that the non-thermal ultrasound and the superficial ultrasound is more beneficial than other modalities. I think the evidence is there that shows it does work in some cases, but not all the time. So I can't say the efficacy will definitely get it better for you, but I think it's definitely worth a try if it does give you some reduction in symptoms. But I understand that some people may say, well, we've tried ultrasound before with no real benefits, so why try for this? I can't give any more of a clear answer than that because the evidence isn't any clearer than that I know of. Yeah,
that's true. And I suppose if it's something that's relatively easy to do, isn't necessarily going to cause any harm to the patient and does eventually help them to avoid an injection or surgery and not go down that pathway, then it's worth a shot.
Yeah, I think it's horses for courses. I think again, if you've got a patient who's not a professional athlete and they don't get ultrasound, they more or less demand it. And they say, well, hang on, why aren't I having ultrasound therapy? Because I've read on Google that ultrasound therapy and shockwave therapy, et cetera, really works. And in some cases, it's a psychological thing as well. And it goes with time. In these patients that have got the time and they can take 8 to 12 weeks off the activities, then it may have got better anyway, but in their mind, the ultrasound helps.
Yeah.
If you're a professional athlete who are gagging at the bit to get back, I would try it in limited fashion and then move on to other options, including steroid injections if needed.
Awesome. You teed me up perfectly for the next one as well, from Alison. So what do you think about shockwave therapy for the treatment of tendinopathy? So I know that's a bit general and research for shockwave will be tendon specific. Is there anything around the hand and wrist?
Mixed experience with it. Some good results. Some I haven't seen any results in at all. Some physios that I use will use it a lot. Some won't. No specific difference between different tendons. I don't think. I think again, why not? Try it, but limited.
Okay. Slightly more expensive than ultrasound, which might play into your decision making, I suppose, depending on how you handling the patient. Let's have a look. Zoe. Okay, so asking about splinting in acute cases of de Quervain's.
Yeah.
So kind of what are the indicators for that, and also how would you use it? So only using during aggravating activities, for example.
Okay, so de Quervain's, the most common patient I get with de Quervain's tendinitis is a new mother. So little baby going from this position, lifting out of the cot all the time, lifted up to feed all the time. So not your professional athlete. Although it's the most common in athletes in the wrist, my most common presentation in the NHS is young mothers. And simply splinting wise, I would give them a Futura splint with a thumb extension and say, in the acute phase where it's very, very painful, wear this for the next 7 to 10 days, take it off, limited use for gentle range of movement to stop stiffness, but wear it all the time because it's very hard for them to pick up the baby and do other things around the house without aggravating it. After that, then wean it off with physiotherapy, eccentric exercises, and just use the splint for heavier activities, and hopefully you'll see a trend where they get better. Splinting for athletes and in the sports world, I'm a bit more aggressive. We'll just splint in the very acute phases for the first 4 or 5 days. If they come to you within a few days, although normally it's more of a long-term presentation. And they can wear it for sports as well, depending on the sport. So, it's unusual for your footballs and people to get this, but they certainly wear it for training in games that they want a customised splint. For racket sports, it has to be a rest from the activity. And lots of physio. I'd rather, in the athletes, the eccentric exercise is taking over the splinting if able. But for the layperson who has to use a hand all the time, then I think splinting is very good, especially for the first 2 weeks.
Awesome. We've got some great questions coming in. Reese, I'm going to try and get to yours because I'll personally upvote that one. So, Camille, are there any negative effects from the corticosteroid injections for tendons or other local structures?
Yes. I've had a lot of cases in the past who have been to see a GP with a presentation of hand and wrist tendinopathy, let's say ECU, tendinitis, ECU pain. The GP will say, try some physio, come back. They try some physio themselves, come back. And the GP will then inject around a tendon blindly without having any investigations done. One of the things here is that this whole broad range of tendinopathy, it might be that patients present actually with a partial tear of a tendon, and that's what's causing the pain rather than one of the prerequisites of your reactive tendinopathy, gentle tendinopathy. And if they've got a tear and you inject steroid, the steroid reduces the chance of that tear from healing and increases the chance of the patient getting back quicker and actually causing a rupture. The rupture rates following steroid are very, very low actually. Really low, and I did look prior for an actual risk factor for it, but there's not one published. It's very, very low. I've had one case of a tendon rupture from steroid injection, and unfortunately for me, it was in a world bodybuilding athlete. It gave me various problems, one of which was a tendinitis of the little finger flexor tendon, and he tried lots and lots of things, but he simply couldn't deadlift without pain in the finger. And we agreed to put a very low dose steroid injection into his finger. He rang me 4 weeks later and said, this is absolutely wonderful. I have no pain. It's worked. It's great. I'm back. I'm competing. And then 2 months later, he rang me and he'd snapped his tendon. Now, whether that was due to the injection or due to him lifting crazy, silly barbells I can never imagine, I don't know. But I'd link it to my injection because it was within the first 3 months. I think if you consent the patient for that, only use low dose steroid. So 5 milligrams Kenalog around the tendon itself, and do it under ultrasound scan as well, so that the steroid injections going peri tendon rather than into the tendon itself. Now, in normal tendons, if you inject, you know you're in the tendon because it's very difficult to put the needle in the tendon, really. You get that good feedback. Whereas in these chronic, really swollen, really scarred up tissues, sometimes it's a bit more difficult. And actually, you could be injecting right into the tendon itself, which I would advise against. So yeah, there are risks of using it. You need to weigh up the benefits against the risks, the individual itself, the profession they're in. As long as it's documented and counted down, I have no problems in using steroid. But I have changed my practice from doing it myself to referring it to my radiologist who'll do it under ultrasound. And I think from a medical legal point of view as well, now the more evidence coming out, I think that's crucial, really.
Yeah, awesome. We'll go probably Reese's question as the last detailed one, and then I might, dependent on time, just a couple of really quick fire ones. But Reese, thanks for this one. Good question. How often do you see neurological involvement with these conditions?
Neurological involvement of the tendon. So can you expand on that any further? Are you talking...
Reese, can you do the raise hand thing, and I can maybe let you verbalise your question? If you can see the raise hand button, I'll let you in. There he is.
Hi, Reese. Oh, I think you've muted him.
Yeah, I'm just going to unmute him.
Okay.
If I can do that. Go on, Reese.
Hello.
Hi, Reese.
Hi. Thanks for a great lecture so far.
No problems. Fire away.
So more neurological involvement being pins and needles, numbness of the fingers and the hand, really. Because I know I hear a lot of people talking about carpal tunnel, and a lot of people say, you know, if it's a wrist problem, bit of involvement with pins and needles, they just say, oh, it's carpal tunnel syndrome, and don't really investigate further.
Fine, okay, I understand. Yeah, no, I mean, very, 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 very common presentation. And you're right. I mean, we talked about the start of the lecture, the difference between the extensor tendons and the flexor tendons. The extensors being very individual in their own tunnels, whereas on the flexor side, basically a carpal tunnel is really, for all want of a better word, a big, huge tendinopathy, because you've got lots of inflammation and pressure inside the carpal tunnel itself. And we do lots of carpal tunnel decompressions, and quite often when you're inside, you'll see this thickened, horrible synovitic type tissue around all the tendons and the median nerve itself. So they can go hand in hand. Carpal tunnel mainly presents with the pins and needles, so the thumb, index, middle finger. Patients will often describe a weakness in their grip. Now, is that due to the neurological symptoms of just the loss of sensation or the altered sensation, or is it due to actually when you're making the grip strength, the tendons not working as they should, or you being inhibited by that sort of neuropathic pain, if you will? I don't know. I wouldn't treat carpal tunnel as a tendinopathy, though. But when you do the treatment for your carpal tunnel, such as a steroid injection, you are in effect doing what we've talked about in this lecture. So you're quite right. You do get symptoms sometimes, but not always. It's unusual for a patient to come in with isolated tendinopathy of the flexor tendons of the wrist. Normally the tendinopathy is distal in the pulleys, so the trigger fingers, tenosynovitis, more distal. If it's in the wrist, though, then yeah, you would expect to find the median nerve symptoms as well.
Brilliant, thank you.
Okay.
Cheers, Reese. Cool. Right, just two last quick fire ones. There are loads of questions, but I think what we'll do, we'll let people know where they can find you on social media or whatnot.
Yeah, I'm happy to answer any questions later on or whenever at all.
Yeah, awesome. So, dead quick fire. Common pathologies for plantar and thenar eminence in the thumb. Which are the most common?
Say that again, sorry, Ollie.
Most common plantar thenar eminence thumb pathologies that you see.
Thenar eminence pathologies.
Yeah.
Injuries really with acute injuries. So golfers' injuries, hitting into hard ground, bruising, edema, swelling, which can play into the recurrent branch of the median nerve, giving loss of sensation to the thumb and swelling. Just time for that one. You need to let it rest. Very, very, very rarely would I recommend a decompression of recurrent branch of the nerve. It's difficult and it's unlikely. I've never really seen any acute problematic sprains of senior eminence, really. Not in my background or field, though.
Cool. So more traumatic stuff, Brill.
Yeah, I think one more volar plate injuries of the metacarpal phalangeal joint with hyperextension of the thumb often give you lots of pain to the senior eminence, and that can be caused by a partial avulsion of the volar plate of the thumb. Again, splinter inflection, and then after 2 weeks of splinting, gentle extension to bring it out. I've had one or two, a complete rupture of the volar plate of the MCP joint, which has had to be reconstructed with 2 small anchors, but unlikely.
Awesome. Right, last one, just because it's getting a lot of love, and then everyone else is going to have to tweet you. Do you recommend any anti-inflammatory medications in management of any of the tendinopathies that we're talking about?
Yes, I do, definitely. Sorry, I'm not sure. I may not put that in. I've stuck more to surgical and interventional things. But yeah, and NSAIDs would be my first line, along with physiotherapy, just to reduce general inflammation around there. No real contraindications unless you've got medical problems with that. I know there's a lot of things about fracture healing and NSAIDs being taken and reduction in union rates, but for tendon problems, yeah, without doubt.
Awesome. Right. Well, we're probably going to have to wrap up the Q&A because I think we could probably go on all night. People are loving the questions. We can see your website there on the slides, mrdavidmurray.com. Where else can people find you and follow up?
On Twitter, you can search with the Murray UK Hand Surgery, or on Instagram for UK Hand Surgery as well. Excellent.
Good stuff. And Andrew, where can we find Steroplast?
Steroplast.co.uk or sterosport.co.uk is our sort of e-commerce site. Or just look us up on social media as well.
We've got the LinkedIn group as well, haven't we, on there for the Injury Rehab Network, so people can look that up and join if you're involved in that locally.
Yeah.
Awesome. Anybody wants to find out any information about BASRaT, you can visit us at basrat.org or at basrat.org on Twitter. That's it, folks. We'll wrap it up there. For the panelists, it'll probably end quite abruptly as I hit stop. So thank you. Thanks, Andrew, for getting us off the ground and getting this organised and putting it all together. David, special thanks to you as well for giving up the time for us this evening. Really, really appreciate it. It was a brilliant lecture. I'm sure people have taken a lot from that. So thank you very much.
Thanks, David. Thanks, Ollie.
Brill. Thanks, Andrew. See you guys.
Bye-bye.
Bye. Thanks, everyone.